welcome. You're here for the Innovation and Social Determinants of Health panel. And I'm so excited to have all of you here. And we have Sarah Rahman, who will be the moderator. And we have Rajiv Pramanik and Leon Clark, and they will all be bringing us on a fantastic journey.
Great. Thank you so much, Viveka, for that introduction. We are so glad to have you join today's HIMSS panel on health equity and social determinants of health. Now, healthcare interests have been squarely focused on the trends of digital health and health equity. Today, what this panel wants to do is to move the lens from the conceptual ideas of innovation and bring that spotlight down to the level of what's happening on the ground. What are organizations doing in practical terms, and where are they in their journey? So today we bring together 3 healthcare organizations from Northern California to share their experiences. And as Viveka mentioned, my name is Sarah Rahman. I am the Associate Chief Medical Informatics Officer at Alameda Health System and a practicing ambulatory internal medicine. Now, Alameda Health System is the safety net organization in Alameda County. And Leon Clark is here with us today. Hello, Leon. He is, as Viveka mentioned, the Vice President and Chief Research and Health Equity Officer at Sutter Health. He has over 25 years of health experience in health equity and finance and works to improve patient access experience in health equity. And of course, we have Rajiv. Hello, Rajiv. Rajiv Pramanik, he's the Chief Health Informatics Officer at Contra Costa Health Services, and he is a practicing emergency medicine physician. CCHS is a county health department with medical, behavioral, and health plan, amongst other divisions. And as Viveka mentioned, we started out with the poll. We thought it'd be interesting to hear from the audience about where you are in your journey. And feel free to enter your comments in the chat. We'll be moderating that. And Viveka, we can start with the first slide. To set up, the next slide. So to set up the background, to set the groundwork, social determinants of health, as defined by the World Health Organization, are the non-medical factors that influence health outcomes. And next slide. It's clearly been recognized that while traditional healthcare can account for up to 10% of health and well-being, these additional social drivers of health, which include the social and environmental factors and individual behavior, can have up to 60% impact on health outcomes. There's growing recognition to see the fundamental need that these need to be addressed to achieve the greater goal of improving health outcomes. And next slide. These social factors can be described through multiple layers of individual lifestyles, social and community networks, and the broader environmental conditions, as well as even more upstream policy levels. So today's panel, we will bring in our own experiences from our healthcare organizations. And as we want to open up the conversation, Leon, maybe you can start by helping us understand more the context of why this is important. Why does this even matter to me?
Yeah, thank you, Sarah, and good afternoon, everyone. I'm happy to be with you. You know, I don't think it's an overstatement to say that these are matters of life and death. Consider that life expectancy for someone in San Francisco is 84 years old, while just across the bay in Center City, Oakland, it's more like 73 years, or a difference of 11 years. When life expectancy is determined by your zip code, you know you have a problem. That's what makes this effort, our shared commitment to identify, understand, and ultimately address the underlying factors that contribute to inequitable health outcomes so important.
And Leon, you mentioned the zip codes and the data around that. So that brings us into the first part of our conversation of the importance of data collection, even before we jump into any implementation and innovation. Data integrity can be a cornerstone to implementing change. And Rajiv, why don't we start off with some of the experiences of Contra Costa and data collection in specifically social determinants of health?
Yeah, I think Leon and I have been talking, and same with you, Sarah, about this for a while. It's like, can't improve things you can't measure. So the idea of how do these things affect us and how do we measure them are of vital importance. The second is care teams have evolved to be much more than the nurse you're seeing and the doctor you're seeing. It's the entire, all the employees in these systems or clinics are part of the care team, and to coordinate that in an effective way. So first part of it is to share why these things and this work is important with your staff. So we did that similar to what Leon was saying. We showed BART stops and how it varies and why it's an important thing to understand and collect. And we standardized that after we shared why it's important, because at first the registration staff's like, what do I have to do with that? Why am I asking such invasive questions? So we started with our race, ethnicity, and preferred language work as part of the first Medicare waiver, the 1115 waiver, I think more than 10 years ago. Some of you may be aware of that. And then we expanded to the SOGI, the sexual orientation, gender identity, and now we're expanding into this area where are you having trouble getting to your medical appointments, transportation, or is housing an issue? Very intimate questions where I think regardless of who is asking and what setting, they need to understand the background of that, and developing and sharing that background with your entire care team is an important way of kind of beginning that standardization process. I think, Leon, you were going to talk a little bit about kind of data consistency and completeness and things also. And I'm going to hand it off to you. I think we're going to the next slide.
Yeah, no, I think we could perhaps stay on that slide and maybe just a few additional thoughts about the importance of data and data collection and doing it consistently. It's the data, in my view, that underpins both effective strategy and innovation. So organizations first have to commit to actually going after the data. That's where Sutter started. I appreciate the prior comment. It's difficult to manage what's not measured. There's also another expression I like, which says that leading organizations measure what matters most. And if social determinants of health, which contributes to inequitable outcomes, is important, then I think you have to measure it. I wanted to share maybe a couple of different thoughts from our learned experience. First, with respect to data collection, I think it's important to really engage your staff. I think intuitively they know the importance of capturing social determinants of health data, but they're also busy. And so establishing standard work, investing in things like change management is essential in that regard. The second thing, and you mentioned it, Rajiv, is making sure that you engage your patients. So understanding that they might have concerns about sharing social data with you, and concerns about how that data might ultimately be used. At Sutter, we've engaged our patient advisors just in that process and helping us understand what concerns our patients might have. And then the last thing I would suggest doing is developing a menu of options for data collection. We have used our online portal just as an example. We've used social workers, we've used medical assistants. Depending on the care setting, we've actually altered our approaches. The one thing we have done is try to not engage our physicians in doing one more additional thing that stands in the way of patient care. I would say with respect to data collection and standard work, you need it, again, to underpin innovation and effective strategy. The other thing that I would encourage organizations to do is actually make the data visual. or visible, particularly amongst the senior leaders in your organization. I think action follows understanding, and we have to make sure that our leaders are understanding exactly the current state and the degree to which we have inequitable outcomes in our own system. The last thing is a commitment to action. So it's one thing to understand, it's quite another to address. And I think ultimately our goal is to deliver equitable outcomes across all the patients that we serve. And so I would just leave you with those three lessons that we've learned in our own experience.
And then we've highlighted the value of having good data. Good data in gives you good data out. And what that does, Leon, is it really facilitates the ability to target your populations. So I'd love to hear more, and I think you've got some slides about Sutter's approach to data collection and share how that data is shared and targeted populations.
Yeah, so if you want to flip to the next slide, this is just a glimpse of a dashboard that we put forward just for social determinants of health. I mean, again, I believe it's difficult to manage what you don't measure. We try to measure everything that matters to the organization, including data collection. So this is just a glimpse to say how well are we doing, or how well are we not doing when it comes to collecting data that's going to inform strategy and inform how we address inequity in our own staff or in our own system. Let's flip to the next slide. So this is really what Sutter is attempting to do. What you're seeing now is an example of our health equity dashboard. We share this with senior executives across our system, both Bay and Valley. What we've attempted to do in this particular dashboard is really synergize social determinants of health data with outcomes data that we already have historically shared with our leadership team. This dashboard applies what we call a health equity index or risk score to patient subgroups based on their differential risk of a bad outcome. In this particular example, we consider the intersection between race and ethnicity, sex, and socioeconomic status as a way, and these have been historically, as you all know, associated with well-known health disparities. We use color coding to prioritize needs, again, based on the extent of a disparity gap. And we can then use this data to target interventions to help close those gaps, tracking progress as we go.
Leon, I love this visual. It's just a wealth of information, and it's simple in so many ways, but so complex in how you used your teamwork to collect the data and present it to your leadership. I'm sure this will spur the interest of a lot of other organizations to look at something similar. What I also love is that it's integrated into the EHR, so it's facilitating workflows from that. If we go to the next slide, and the one after that, I wanted to share a little bit about data collection from Alameda Health System. We had an extended deep dive on how to approach race and ethnicity. There was a huge other category that was being collected. And being a safety net, there is a very wide diversity in our population profiles. So there are definitely reporting rules for race and ethnicity, and that's on the left-hand of the slide. But some of the gray areas, that race is more of a social construct and ethnicity is more of a shared culture. And so there was really a gray zone, leaving a big bulk to other. And what we did is we extended the options out for each of those categories to that middle part of the slide. And that really opened up for better data collection, more accuracy, more detailed. And so you can see that Asian category opened up to 9 different options, and the slicer dicer gives you more results. So a fundamental pillar of using innovation and implementing any changes are making sure you have good data coming in, as the three organizations all agree on that. And now that we've established that, this gives us a chance to target populations and implement changes on the individual level. Now, Rajiv, you've had some great successful wins at Contra Costa. We'd love to hear more about your shared lessons and experiences.
Yeah, I mean, I think, Sarah, we're transitioning from, we have all this aggregate view, even with certain communities have different needs. So how do you individualize your social drivers and the interventions around it? So it may be as simple as matching clinicians or care team members with the preferred language, proximity types of data sets, or it can be more complex, like assigning case management to someone with a social worker with substance use background or a mental health background, or just a housing background, depending on what driver those patients shared are really affecting them. So in the SDOH work, I think, Leon, you were saying social drivers of health, not determinants, because hopefully we can change the trajectory we're on, right? But in that area, like, which are the drivers affecting you, and then match that up with the interventions. One of the things that we did was around the transportation as part of our second prime or 1115 Medi-Cal waiver. And that was around building in transportation, using a pot of money we got from the state as a pilot, and building it into the EHR. We wanted to make it easy for our staff to do the right thing, right? So we made it as part of your EHR, you can use rideshare and Lyft and get transportation arranged. And we set out claims and automated that. As you know now, ride and transportation is a Medi-Cal benefit. So this was like a precursor to things that affect policy long-term. But it really helps some of these marginalized communities and address some equity things where transportation becomes an issue to access care, and sharing that with your team. So if they're late, you have some empathy of what's making them late, right? It's not 15 minutes, too bad, you missed your appointment, reschedule. It's 15 minutes, but I see that riding is a challenge for you. And sure, we can fit you in somehow. Getting that empathy and learning each other's kind of details.
And Rajiv, I love how you've used this targeted approach to also facilitate the EHR, having it integrated into Epic, so the provider's workflow becomes seamless and more readily able to help the patient. I can't emphasize that enough. This is really true ways you've used innovation to collect data, modify it, put it in, collaborate with your community resources. I really think that's just fabulous. A really, really great lesson learned. And the same way with the EHR integration, Leon, the dashboards that you've shown us that have this great data, tell us more about how you can drill down into that data and use that.
Well, one of the things I would just quickly point out, I think the data that we collect, the dashboards that we publish, point the way. But from an organizational standpoint, I think our obligation is actually to act, is to commit to action. And so what we try to do is cascade the dashboards down to the lowest level possible. So each facility will ultimately get a dashboard that indicates where they have inequitable outcomes in their catchment area. The next thing, I think, what we've attempted to do, it's a works in progress, is to develop an accountability framework. So someone needs to come in every day who feels an accountability and a responsibility for closing the gap in terms of equitable outcomes. And so it's not just using the data, it's or capturing the data, it's making it visible and publishing it, making sure that the leaders in the organization have a sense of what's happening on the ground, and then following through and making sure that there is accountability in the system. Somebody, again, at a senior level needs to be responsible, or feel responsible and accountable for making progress over time. So hopefully that addresses your question.
Absolutely. Again, having it, you know, if this data is locked away in some file cabinet where no one can see it or action on it, that's of no use. But having it integrated into a system to share with leaders and providers, I think, is really valuable. And you can click on that red and drill down where do I need to focus my attention. So I think that's a real key point. I know at Alameda Health System, we have also used a very targeted approach, trying to make it easy for our patients and providers. We've partnered with Well Health for texting our patients when we find there's a health maintenance gap, let's say in pap smears. We target that population, text them for outreach, and we've had actually really good response. So sometimes simple maneuvers done well can be very effective. It's really thoughtfully approaching that. And so as we're discussing this conversation of collecting data and targeting our populations, there's also the next layer of targeting that can be done at the community level, right? Social determinants of health are community issues. Rajiv, help us understand how this can work. You've done a lot of work in this arena, and help us understand where we can, as other organizations, partner with our communities.
Well, I think it goes back down to the social drivers that affect our health. The health in the broader sense is the communities we live in, the air we breathe, the parks we walk. It's well beyond the four corners of your hospital or clinic. So it's essential if we really want to improve our patients, members, our community's health, we really start working with those community-based organizations and network with each other and leverage each other. It's kind of like HIMSS getting us all together. It's really learning from each other and working with each other. We've partnered with multiple CBOs, and we started to get some feedback on which is working with our patients. How are we sending you the right info for you to do the right thing, and generating that data and then leveraging the ones that are working better, trying to improve the ones that aren't working better and why. And even then, like, you want to send a VA patient to a VA specific CBO because they may be approved for that. So using the data, but also using kind of that full cycle of data and improve upon each other. And also then we've also worked with external research organizations, right? Academic, we're not an academic organization, but we brought in researchers from UC Berkeley, USC. I'm sure you guys have all done the same to really help us evaluate. What are we doing? We think it's better, we don't think it's better. Give us an academic viewpoint of what's really the effectiveness of what we're doing and where we should focus on more.
And you've done some work with Whole Person Collaborative in Berkeley. What's that experience been like?
You mean the whole person care pilots? And CalAIM is kind of the result of some of that. So each county and many safety net institutions were able to apply for whole person pilot money and develop their own interventions using innovations. The transportation was one of many innovation things we applied and got funding for that we did. And then we had UC Berkeley evaluate, was a part of this effective, was it not? We're working on a publication right now with the annals on kind of looking around that and seeing and documenting that. Things like that are going forward now in CalAIM as part of the case management, but also as community supports. Some of you may have heard the word ILOS, which is now community support. And that's around like asthma remediation at houses, right? We find like mold abatement, things like that. Individual have asthma, you ask them about their housing status. You find out if you can give a benefit to them to improve that house and get better outcomes for their health.
Oh, that's great. That's great. And I know you've mentioned in the past, when you choose your community-based organizations, is it a wide array, or are there just a few that you use? Are there?
Yeah, as you get that full cycle, when we first started this, we actually worked with Kaiser in the west part of Contra Costa County in the Richmond area. And we got some money to do, we had UC Berkeley students help navigate like Promotora CHWs to connect with our patients and connect with the CBO. They had the time to find out what happened because there's a lot of interoperability as health institutions work with CBOs as far as what's PHI, et cetera, and consent. But they found out from, hey, if I referred you to this food bank, what happened? I'll call you next week. Did you get the food? Yes or no? It was interesting. We found that 80% of the needs were met by like 15 or 10% of the CBOs, where the rest weren't as effective. So giving them that feedback as I think how they can be effective and what are we doing to make the ones we're referring to more effective. So I think getting that data and helped us learn and improve the whole process.
So are you, go ahead, Leon.
If I could maybe
Yeah,
just
absolutely.
first on the importance of partnering. I mean, if I had to, put a theme on it, I would say, the road to advancing health equity runs through communities. I think there's oftentimes a missing element, and that is how to think about your community-based partners and how do we evaluate them. Back to the earlier point, I think there's a couple of things I would recommend because we do the same, right? We operate across 23 counties. We serve the very rich, the very poor. What I know about communities is that they're all different. The needs are different. And so we have to think strategically about it. One, I would say the organization has to understand or think about what it wants as an outcome and how you would ultimately measure that. Number two, I think you have to really think about your partners. Do you have are you aligned in your thinking? Are you aligned in your capabilities? So you want to work with groups and organizations that can amplify what you do or close a gap in your own capabilities. And then the third thing, I think we have to think about the long-term commitment. So what does it take to really be effective over the long run? And in some instances, we as provider systems have to help support the community-based organizations in the delivery of whatever the services are that we provide. I just wanted to mention that because, again, I do think that the road to health equity runs through the community, and we have to understand that and engage them in our outreach efforts and our solutions development for sure.
Leanna, I think your points are so spot on. If you think of social drivers, social determinants of health, there are community factors. It's taking you into what's going on into your community and environment. And outside of our healthcare organizations, we really have to think outside the box of how to partner to address those community issues, problems, and pull the bright spots as well by connecting with community health workers, for example. Have you had any experience with community health workers and partnering with them, bringing the level and the experience of the lay people, of the people closest to our patients into the picture?
Rajiv, did you want to take that one? I'll make some general comments. One of the things that we learned during COVID was that there are real issues of trust in the community, and we're not the most trusted voice in the community. And so you want to ensure that you can readily identify and work with those trusted voices who serve patients that we also serve. So that would be one thing to consider in that context.
Yeah, we work.
I'm sorry, Rajiv. The other thing I would say is we're not. We'll accept help from anybody. so we're humble as we need to be when we approach community-based organizations. We're not. Again, we're not the trusted voice in many instances. We don't know everything. And so it requires, I think, organizations like ours to become more humble in understanding the needs of the organization or the patients that we serve through these community-based organizations. We just have to make sure that we have the right approach with humility when we come and partner.
I think, Leon, you had mentioned when we had our own conversations of working with Roots in Oakland, or when we worked with United Latino Voices, and really using those more trusted voices in the smaller communities and learning from them, and then empowering them, and then kind of leveraging and coordinating with them. An example where we used an equity-based platform for vaccinations was kind of, we had population centers, but we also had areas that had lower transportation access. Mm-hmm. And we had to blend that together with, this people are here, but these people can't get to here. So where should we put our large public health vaccination, mass vaccination sites or testing sites? So really looking at community equity, community access, community resources, and trying to figure out something where everybody could get vaccinated that wants to get vaccinated. And then working with the trusted voices to spread, potentially help with information sharing and why is it efficacious, why is it not, etc. So I think, Leon, you were talking about Roots when we talked, and that was a great subject. I don't know if you want to share that.
Well, I think we had used our data, as we indicated, to identify and risk stratify cohorts of patients who are at risk of a bad outcome, in part because of the information we had about social determinants of health. Some of it was census data. We know where there's pockets of poverty, just as an example, so we could be a little more targeted and pinpointed in terms of our outreach strategies. And so that's how we identified some of the organizations that we ultimately worked with. The idea was to bring information and guidance and resources to patients right where they are, rather than expecting them to navigate a very complex healthcare system that, as Sarah pointed out, I've worked in healthcare for 25 years. I still don't know how to navigate the system effectively. And so how can we, those of us who work in healthcare, if we can't figure it out, then our patients who are most vulnerable can't either. And so I believe in meeting them right where they are, and trying to provide, again, the resources that are needed to support those who are, historically marginalized.
I think the direction of the conversation is actually on point. We had been discussing from organizational perspectives of what we're doing, but if we flip the conversation as we have been doing and looking at the patient perspective, where are the challenges for all of this great innovation and technology? How does the patient feel about it? What are the challenges they have? We talked about trust, privacy. Those are huge issues. This is why the community-based part, community health workers partnering with people in the community can make a difference in success and adoption. I think some other factors are digital literacy, right? So even if you have trust, do folks have the technology, the broadband, the internet? Even if you gave them all of that, how about the digital literacy? Do they know how to use this? What's our role in facilitating that education and support? Where is the innovation around that? The health literacy, the digital literacy. I know different organizations have approached it differently. At Alameda, we have a tech advocate program where the patients will be called ahead of time of their appointment to assist them with sign-ups for video visits. Where are your organizations with that aspect of looking at from the patient lens and support?
I mean, I think this is where I'm sure we've all done similar things. We also put up COVID sped up a lot of this analysis and data and use for telehealth and virtual visits. We also put up a desk to help with our patients and kind of using the web portal and all of this technology to reach us, right? We shut down, like, we can't be seen, don't come. But wait, what do we do now? So we also stood up a desk that automatically calls a patient, asks them if they need support, if they've never done this for the first time, or if they want to, there's a number to them to help second time around. And similarly for our clinicians, we had to put up, because they were also navigating a whole new field. It's like, okay, before you wait in the clinic and you go to their room, now it's like you got to log on. Zoom, Teams, whatever you have. It became a whole new, and then learning the soft skills, right? Patients, it's very easy to navigate each other physically, but then how do they talk to you, and how do we talk to them? How do we kind of communicate and listen and hear things that are very different in a virtual world?
Yeah, I'm a big fan of technology as a way to expand our reach into marginalized community, providing information, guidance, and care to those who need it. But I'd also, as the Chief Research Officer at Center, I want to adopt evidence or push out evidence-based solutions. And I still think that the jury's out in terms of whether a digital practice or remote care is actually leading to better outcomes. And so we proceed with caution. We try to use data where we can find it to really determine whether we're truly helping people. I think the ultimate goal is to produce equitable outcomes. And anything short of that, I think, is short of our goal. I'll just say, one other thing about just innovation, generally speaking, that might sound like I'm talking out of both sides of my mouth. On one hand, I'm a firm believer in evidence-based solutions, but I also think that sometimes we get in our own way by choosing perfection over progress. And a lot of times in the innovation space, we have to just try things. Evaluate whether they work, and I'm not suggesting we do things that don't work, but we have to have, as part of any effort that we make, we have to have some way to evaluate whether it's working or not, using our platforms or digital channels to share best practices, things of that nature, if it does work. But we even in the absence of really good data, intuitively we know, historically we have known that there's disparities in our system. And so it's not enough, I think, to just understand and accept and study the fact that we have health disparities. Ultimately, we have to do something. And so that's my encouragement today, is to do something, try it, see what works, and spread it if it works. But don't wait forever. Our patients are waiting is sort of how I see it. They're waiting for us to get our act together, and we've got to meet them right where they are in that context.
I was going to say, I think based on the poll, there's a large segment that haven't been collecting social drivers of health or determinants, and for now, many of the payers and things, these are kind of pay for reporting, or you're doing great work and may help you to drive your own outcomes and own interests, but ultimately these are going to be required of you. And so learning your data sets, learning to innovate and come up with interventions or something, whoever's, you'd be ahead of your time and ways to approach this.
Yeah, we've talked about the fact that the sticks are coming, right? Carrots and sticks.
Yeah.
I'd like to work on the carrot side. It's a lot more fun. So how can we incentivize our staff, our physicians to do the right thing? Because we're going to be required, to your point, to collect the data, but ultimately to deliver results that are more equitable. That's the ultimate goal, and that's what we're going to ultimately be held accountable for. But the time to develop processes, the time that lead to data collection, that you can use to develop solutions to address inequitable outcomes, I think the time to do that is right now.
And I think we all touched on the shared experience of learning from others. HIMSS giving us this platform to share where we are in our journey, what have we learned to help others. I think this is very much at the beginning of the journey. We look forward to HIMSS offering other opportunities to share what we're doing. I think we've also touched on, we looked at the individual level, the community level, and the importance of following policy and regulations as they come through, carrots and sticks, as Leon put it. You know, for example, CalAIM, they're promoting the initiatives to collect the social determinants of health in their Medi-Cal populations. And that's, you know, soon to be mandated, soon will be required, and really understanding how others are doing this and sharing those lessons learned are key things that we can do to keep up with what the requirements are eventually going to be. As we are putting together these journeys, Viveka, do you want to share the poll results? I think that would be interesting to see where folks are on this journey of social determinants of health and data collection.
Absolutely. Do you see it now or no?
Do folks see? I see it. Can other folks see it?
I'll read. The numbers changed a little bit because I waited to close the poll. But basically, 41% said that they had not started collecting social determinants of health data. 27 are in the process of doing so, and 32% are already doing it.
Okay.
Yeah.
So that's,
and we had about 43% participation rate. So thank you, everybody.
Yes, thank you. That really tells you a lot, where 2/3 are not really quite there yet in collecting. And as we talked about quite a bit early on, the importance of having good data in will help you get good data out and really target. And that's where the opportunity to really innovate and use these tools can be, amazing, as Rajiv pointed out, with Lift Share integrated into Epic and automatically, contacts the patient, the lift, and the payment. I mean, that's clearly a big win. I think as we're slowly trying to wrap up this panel talk, that there's some key things we want to highlight as the take home messages. Number one are the data collection, data standards, right? Using your whole team to get that right from the get-go. If you're starting on your journey, pay attention to that. If you use good data, what we're also saying is use a targeted approach. One size does not fit all. Really understand what your clinical question and who you're targeting in your efforts. We're also emphasizing the integration into the electronic health record can really take you so much further, looking at Sutter's dashboard and how Leon can drill down and figure out exactly what's going on with certain populations. We also are emphasizing community collaboration. This is where the issues need to be addressed. Integrate the patient, the feedback from the community, collaborate with them to get results on a better cultural understanding of what's happening. And then, of course, following policy and the regulatory environment. I think this was a panel on innovation, health equity, and social determinants of health. What we also tried to show is that innovation can be used in different ways. It's not just a tool. Innovation can be how you use the think tank of your organization to shape your clinical question of where you want to go. It can be innovation around how you shape your care team in engaging your registration and your care team to ask these questions. It can be innovation around how you leverage your community. So innovation is many steps along the way. Technology is one part of it and can certainly facilitate. Again, using shared lessons, I learned so much in setting up this panel from Rajiv and Leon and their experiences. shared experiences, shared learned lessons, using HIMSS as a platform going forward. We look forward to that. And in our last few minutes, I'll ask my fellow panelists, any final thoughts? Reggie, where do you see this conversation happening a year from now, if we are joining HIMSS again a year from now?
I think for the 2/3 that from a system level don't feel their staff is doing this, I think the question is their staff isn't doing this in a standard way. You ask any nurse, any clinician out there, they know some of their patients and the challenges they have with housing, with substance, with work, with what all these social drivers. It's just the system isn't capturing or doing that, but the clinicians are learning it. They're just not documenting it in a way that someone else knows. So I think if you begin this journey, you'll be able to start leveraging each other better. And we all know that our primary care homes and teams are really, really busy. And the more we can leverage larger teams to help support them, the better outcomes we'll have in the health of our patients. So I would say that would be for the 2/3 that haven't done this work yet, that you already are doing it, but try to standard and understand how you're doing it and improve upon that.
And Leon, I'll ask you a slightly different one. Where do you think the challenge is? You've been working with health equity for a long time and have a lot of experience. Where do you see the challenges? Where should the challenges be in the next year that we should focus our attention on?
Yeah, so I think about how complex ultimately delivering equitable outcomes is. I think organizations, healthcare delivery organizations have to recognize that this is not work that they can do alone, that it requires partners. Being a good partner requires that we recognize and understand what our capabilities are and what are, more importantly, what our capabilities aren't, and how we can need to fill in with those who can deliver the services that our patients rely on. So that would be one. The other difficulty that I have seen, that I advocate for within our own system, is not to settle for activity over real progress, right? Sometimes we count the number of things that we're doing that, or the efforts rather than progress. So ultimately, what we want to deliver is better outcomes. Let that be the ultimate line of sight, and not settle for the attempts, right? That would be the final advice. And the last thing, perhaps is just leadership commitment. It's going to take a while for those who haven't started. Just recognize this is not a quick fix. It requires sustained commitment from leaders. So leadership engagement, a sustained commitment, I think, is necessary to really deliver results. And so those would be the three things that I would offer.
And interesting, what I'm hearing is from both of you, we really need to engage from both ends of the spectrum, leadership down to the care teams and registration, as well as the patient. This is a full scope of work to be done. Great. I appreciate you both joining in the conversation today. Viveka, are there some questions that we may take now? I know there's a separate breakout later.
There are. If I may share one question, I've been trying to, and I think just because we've had such a rich conversation, and we also want to hear from the audience as well, I just want to urge everybody to also reach out to our panel, and we can continue this conversation. But one question, right, is, and I know, Rajiv, some of you spoke to this in terms of the primary care doctors don't have time to do it. What's the best strategies for collecting this data in a way that uses the time for the whole care team? And so if you want to circle back on that, maybe.
I mean, I think all three of us mentioned there isn't a one-size answer for this, right? The key is there may be multiple places you see that patient, that member, and multiple opportunities. but you definitely don't want the busiest person, whoever that is on the care team at whatever setting, be doing this as added work. You might want to fit it in somewhere else. You might also say for patients that are capable, leverage a different modality, be it some survey beforehand or afterhand or a certain other time. We do health assessments throughout and build this on somewhere else. But so there isn't a kind of one answer that says the best. I would say you'd have to figure that out depending on how your care team works and who has the time and who's in this realm. But the key is the entire care team needs to understand this is an important item, though, that they need to figure out how to, bring into their information.
I would say use the ones that work best within your workflow. We've encouraged, we've pushed out surveys through our online portal. We've used in acute settings social workers. We've used medical assistants in ambulatory settings. I think it's going to differ depending on the care setting. But again, I think you want to do it in a way that is works within the workflow that you've established. And to the earlier point, engaging your both your staff and your patients are important in that regard. You want to have standard work processes. And you want to support them with effective communications and change management. I would say those are the key.
And I would echo the statements. I think it was David Nessum who brought up this question. Working in the primary care environment, I wholeheartedly agree that we need to expand that concept of a care team and the approach of how this work is done for our patients. There are so many regulatory requirements placed on the primary care doctor that it really is almost hindering the way we can address the clinical concerns that come up. And looking at this in different layers, the short term of why they're in the office today and the long-term marathon of how we're going to address the care. So I think this is a very, very important question. And I think there are going to be creative answers to this.
Another question was also, how do we deal with the trauma and stress in this identified population? How can we manage the consequences of the stress and trauma, for example?
In the patient,
great.
Providers.
Everybody involved, probably.
The silence was an answer.
These are intimate situations. I think some behavioral health delivery systems have trauma-informed services. Some medical systems are also implementing those and really getting to the understanding how the patient has had trauma, the clinicians with that patient get trauma, and how to address and approach that. I know in the pediatric field, the ACEs work that our previous Surgeon General started really started saying at how that trauma from early childhood affects outcomes long-term along other social drivers, right? But I don't think I have an answer to this other than it's an important area of further an ongoing work.
I think this is a challenge for sure. Again, there's two aspects: the short term when the patient's in your office and the long term health. For Alameda Health System, we are fortunate to have integrated behavioral health. If I see a patient in my office, I can do a warm handoff that day and have behavioral health come in and talk to the patient right after I'm done with them. In most circumstances, not all clinics, but definitely moving towards that model, because that mental health space is so important to clinical care. A great question.
Nothing more to add. I think my colleagues addressed it.
And I think we have 5 more minutes. I'm going to also ask you this question that we got, which was, how about patient engagement, particularly on the preventive side? Does anyone want to comment on that? Successes and challenges?
I think we all can comment. Leon, why don't you go first? I can add some stuff.
Well, I think engaging patients is probably the most important thing to do to understand, what their unmet needs are. I think that has to be intentional and proactive. In our system, we try to use patient advisors to help us understand what the needs of our patients are. I think if you listen, they'll tell you. And I think, again, from my point of view, I think the system is really, really tough to navigate. And so we have to meet our patients where they are. And that requires, I think, us reaching out more so than expecting the patient to, come in. So that's kind of how I think about it. I think the best way to understand is to ask. And so having mechanisms to do that, to hear the voice of our patients, I think is most important.
And also, I think that's where we talked about this earlier, using trusted partners, the community health workers, promotoras, American health conductors. Who do they trust? Who knows what they're going through? And if there's something you want to emphasize to them that you think will improve their health outcome, using those trusted channels. Maybe go, if they're religious, go to their place of worship, maybe schools or other avenues. And that's where the CBO kind of a coordination helps. I mean, with COVID, we know we have to use all of these mechanisms to help spread information. So really engaging them, there isn't another automatic, this works, this didn't. Sometimes you have to incentivize it and see if incentivizing works or doesn't work. But those are all multiple innovative methods that I would recommend people try. The other thing, I think we talked about this before, is just because one thing didn't work once doesn't mean you shouldn't try it again somewhere else or even again at the same place. It's an interesting thing. I mean, we know that we used the example of back surgery. I'm not a surgeon, but back surgeons probably, they still do back surgery. It's not effective for all back problems. And 1/3 of the people who have back surgery historically get worse. That doesn't mean stop doing back surgery. I would use that for innovation too. Doesn't work, maybe think about it, iterate it, change it, and try it again somewhere else or learn. I mean, it's a continual process, and there's no necessarily obvious wrong thing to do or obvious right thing to do in this realm.
Yeah, the worst thing is to do nothing. And so I would just encourage us again to commit to action. If something doesn't work, if you're going to fail fast and pivot to the next thing, but you have to go to the next thing. And so those are my thoughts. You're exactly right.
Right, and I'll echo the topic of trust. I know if my MA is Spanish speaking, the patient is going to get the lowdown on me from the MA. This is what she said, is that the right? So keeping diversity, not just within community and community health workers, keeping diversity in our staff and our providers definitely improves outcomes. That's been shown. When you have someone who looks like you, speaks like you are more likely to listen. So those social aspects are really important to establish trust.
This is so fabulous, and I cannot thank you enough for this fantastic panel. This is a really rich conversation, and I love how engaged everybody was in the chat. And if we didn't get to your questions, please remember that later on today, there will be opportunities to network and ask more questions of the panel. And we'll also be, you can reach out to us by email, and we would love to continue this conversation. And if you would like more content like this from HIMSS Northern California and HIMSS nationwide, please let them know, because we're obviously very passionate about this. And I just want to thank the panelists again for your time and willingness to share. And we will see you hopefully at the networking. And then please also take the chance to go to the expo floor. There's some great new innovators in that space who would love to see some of the participants, and of course our sponsors as well. So I just want to thank everybody for being here, and I can look forward to continuing the conversation. Bye.